Now I'd invite Dr. Anil for the much awaited topic of medical legal aspect in ROP, which we know is very, very important. And we should all must pay attention once we are practicing ROP to what he says.
So, good morning to everyone, and thank you, Dr. Subina and Professor Dogra, for this opportunity. So, why this is the last presentation that is being kept is none of us should land up in this problem. So, that is the first thing that I'd like to tell. But how to avoid that is that I think I can see Dr. Samarth Agrawal is also there. We had this nice article that was summarized with Dr. Anand Vinekar, where Dr. Samarth has nicely summarized all the medical legal litigations that were seen in India over last 1 or 2 decades. And in that article, what we have seen is that most of the litigations were against the pediatrician. However, some of the times even the ophthalmologist, if not doing appropriate kind of documentation, can see themselves in a problem. So as a pediatrician, I think, though it's not the day preterm babies are admitted to this NICU, priming of these parents for ROP screening is a role of pediatrician, and that helps part of and the ophthalmologist. And if we are practicing ROP screening in India, we have our Indian guidelines and we should stick to them, that babies less than 34 weeks and weighing less than 2000 grams should be screened for ROP. And yes, everyone has seen that we tend to see babies which are larger, they tend to develop a treatable or severe form of ROP. So even larger babies should not be excluded, and any baby that has not received oxygen, okay, we should not deny ROP screening for the baby. It might be sometimes, yeah, particularly in SNCUs, we tend to get babies which are actually IUGR, and most of the mothers, they are not really literally aware of the EDD. So ROP screening, even if the pediatrician asks to do for a term baby, we should not hesitate and we should do it rather than missing out, because most our RBSK guidelines are making it a comprehensive ophthalmic examination rather than just ROP screening. And by any chance, we should not miss out something like retinoblastoma at that age also. So do not hesitate and opt out of the ROP screening. So again, most of the baby or ROP or treatable form of ROP is a disease of sick infants. So it is safe to do ROP screening even if the babies are ventilated. Again, so be confident, you know that the baby is fine and you will be comfortably doing ROP screening. So do it for severe babies. Dr. Ajay was also talking at our place. We are following this, that we take ROP consent for ROP screening as well. And I think it should be a recommended method. However, technically and ideally following it might be difficult, but whenever it comes to medical legal implication, these are things which would possibly save us. If the babies are being seen in our routine ophthalmic OPD, we should be prioritizing them. We should say them early than typically waiting them. And if we have a specially designated room for such examination that is warm enough or as good as a NICU, that is a good thing that we can have. Again, everything that we are doing in NICU has to be followed for in seeing any baby, even in our OPD also. So all aseptic precautions are to be followed. Babies are best to be seen in NICUs if it is possible, and all the aseptic precautions are to be taken. Explaining the parents, if it is a good thing, we have a ROP team, we definitely tend to counsel, and it is a good idea to develop a team so that these parents, they are primed about need for ROP screening, the method of ROP screening. At my place, most of our pediatrician and pediatric nurses, they tend to prime the parents, so they are not worried and they will not be after us if they see the swollen lid after ROP screening. So their collaboration between the pediatrician and ophthalmologist is must, and it's a good idea to inquire about the other twins, or in case of multiple gestation, what about the other babies. Sometimes they are not brought for screening, we should always get them screened also. So again, the last, I think this is the most important part of any litigation. Documentation is the most important thing that can save us, or it can put us in trouble if it is being done in a wrong or inappropriate way. So I think Dr. Samarth will agree with that. some of the litigation that has been led, it was stated that anything which was not written on the NICU notes, that means dilatation was not done. So we practice that these are pre-printed things which are available at our form, and the method of examination and dilatation has to be mentioned on the examination sheet. The patient's demographic profile, all the risk factors for ROP, the silent anterior segment findings has to be documented. Again, I think I will not talk about ICROP3, but we should follow the most recent and ICROP3 guidelines for documenting the zone and the stages of the ROP. So I think again, ICROP3 will be calling this as incompletely vascularized retina. So we should be, if there is no ROP, there is incompletely vascularized retina, then we should mention that it is incompletely vascularized zone 2, zone 3 retina. So just writing plain no ROP doesn't mean anything and doesn't carry any message. So if you are encountering APROP, it is very important, at least in Indian scenario, the zone of APROP. Again, I will be calling it as APROP because mentioning the zone is very important in APROP, because the prognosis and the treatment management is entirely different. Again, it's a good idea to write additional findings which are relevant to that particular case. For example, presence of ridge hemorrhages, then popcorn lesion. These are important thing, and whenever in doubt, never hesitate to take a second opinion. If you have a vitreoretina colleague with you, it is a good idea to take a second opinion. And mentioning the pediatric status or systemic condition, about the status of hemoglobin, any recent history of blood transfusion, history of sepsis, that has to be documented as far as possible, because all these are part of good documentation and will prove to save you in cases of any litigation. And again, this is one part which this is one of my software or how we do it. The date of follow-up has to be in the form of date, and date doesn't mean just numerical values. It is good idea to write something like 9 February 2019, because we don't have any confusion between day, month, and at least never write it in the form of 10 days, 1 week, 3 weeks. It doesn't carry any meaning in ROP screening. Please avoid that. So again, if you have a good handwriting, it is good thing to have, but if you don't, then it is good to have a printed summary, and that saves most of our time. And having a good summary or good legible handwriting is saving you something which is not visible or cannot be read by the court, then that will prove against you. And whenever possible, we should draw diagrams if things are difficult to describe. And whenever possible, if we have access to photographic documentation, even with there are now most of us can afford the fundus cameras, then there are newer technologies where you can use smartphone. So always try and possibly do a photographic documentation. That is very important, and now it is part of the standard of care in the documentation. And use inappropriate terms which will be proving against you in the court of law. Should not use anything like grade, no ROP, posterior pole is normal. Try and avoid all these things. And whenever we are trying to discharge any baby from a ROP screening, then it is good idea that they will be requiring follow-up for refraction or strabismus. That has to be explained to the parents and has to be documented on the file also. So again, a need for regular follow-up has to be explained, and treatment has to be the summary if you are providing, it has to be legibly signed and documented whenever possible. Explaining the findings of examination to the parents is extremely important. Same thing has to be communicated to the pediatrician, because he will play an important role in converting from someone to avascular retina to ROP, and from ROP to a treatable ROP. Correction of these factors will make an impact on the patient's outcome. And treatment has to be done after systemic fixing, and laser is the standard of care for ROP. It has to be done in presence of APROP, and the indication for ROP has to be there on your file, and you should not be treating in absence of plus disease, or the plus disease has to be there on your papers for it. And whenever treatment is indicated, in most of the cases has to be done within 72 hours, or in cases of APROP within 24 hours. And while we are administering the treatment, we should take care all the things that there is no hypoglycemia, there is no hypothermia. All the precautions has to be taken. If you are doing treatment and if you are not experienced enough, then it is better to refer that case rather than doing something which is not appropriate. So, and follow-up, again explaining about the refractive error, need for follow-up is extremely important. Anti-VEGF, as ma'am has said, what I will say is we should avoid the indiscriminate use and take a good written informed consent. Again, this was one of our publication from the Indian IROP Society group, where we usually tend to recommend that babies with APROP in the zone 1, they are the ideal candidate for APROP. And success rate in even in the best of the cases is around 90 to 95% of the cases. It is very important to explain to the parents that's around 10 to 5% of the cases, and those usually with APROP may still need surgical treatment. That has to be explained, and unusual recurrences can be seen with anti-VEGF. That has to be explained to the patients. So to summarize, I think we should follow the preferred practice pattern, and that is there in the standard of care. Counsel the parents appropriately, that is the most crucial part, and documentation is important, and we should be keeping ourselves updated with the most recent management strategies and classification. And last thing is, I think have a very good professional indemnity, at least more than 2 crores as of now, and that can save you if something goes wrong. Thank you.